for CHD. So without wasting any further time, Professor Priya, please start.
Thank you. Thank you. Good afternoon, chairpersons, dear friends. So I'll be talking about how do we optimize CT acquisition and analysis for CHD. Now, when we talk about CT, doing CT in patients with CHD, this is a different ball game altogether. You know, you have patients who are small, who have, smaller hearts, who have high heart rate, who are not going to hold breath, and are also going to move around while you're acquiring the CTs. So you need to really, work upon your CT protocol so that you get the best out of whatever, you can do. So let's start. So when we talk about optimization, the very first thing is whether this CT which has been asked for is really the one investigation which you do. Now, the problem we all know is the radiation. We are going to give contrast, we are going to give radiation to these small kids. So, is CT the way to go in CHD? We all know actually one would prefer to do MRI in these patients because of the very, very big reason of it not involving any ionizing radiation. Also, the MRI would give you a 3D visualization of the complex anatomy, will give you the anatomical information besides also the functional and hemodynamic assessment also. So actually, MRI would be the way to go. The only problem is it is a long procedure. You will need anesthesia for these kids, and you now have to weigh your risk versus benefit for doing MR versus CT, which you can do with no or limited sedation. Also, if the patient has got also, if you don't have cardiac MR available, that is a big issue again. So the cardiac MR has to be available. There should be people who can read it, acquire it. So that also is a problem. Also, if the child has got MR incompatible implants or has got a foreign body which precludes MR, putting him in the scanner. Then if you want to have a look at the lung parenchyma, skeletal abnormalities or airway problems where CT would be a better modality to do. Also, if you want to evaluate the coronary arteries. So CMR would not be preferred if all these things are to be required. But before you send the patient, again, ask yourself, does this study indication justify the risk of doing CT, giving the radiation and the contrast exposure, the anesthesia which will be required? Will CT answer the clinical question? You have already done most of the times, the patient already have had a echo. So is it other, whatever findings you are going to get from the CT, will it affect your clinical management of these patients? And if yes, your answer is yes, then you can do CT in patients who are having complex cardiac anatomy. So I have highlighted anatomy because this is the only information which the CT will give you. So anatomical information, the best obtained is by the CT because of its high resolution, high spatial resolution. So for complex cardiac anatomy, for extra cardiac anatomy, where that is, if you want to see the airways, you want to see the lungs, any skeletal abnormalities, any calcifications, so CT is the way to go. If you want to also simultaneously see coronary artery or any, for that matter, any small structure, be it apicollaterals, so all those can be better seen with CT. For repaired CHD, again, MR, obviously, since you want functional information, hemodynamic information regarding your shunts, etc., MRI would be the way to go. But if you are interested only in the morphology, the anatomy, then you can go for the CT. Also, peripheral pulmonary anatomy is better seen on CT versus MRI. So an optimal imaging environment for doing CT in these pediatric groups would obviously, once you have communicated with the referring physician, you talk to them, ask them what is the indication, what is it that they are looking for? Is the CT investigation the way to go in this child? Once you have decided you're going to do the CT, one would require a good CT scanner. A good means a CT scanner which is 64 slice and above and should have a ECG gating capability. You would need anesthesia backup and an appropriate resuscitation equipment. You obviously need a good technologist, a good radiographer, a good radiologist to tailor make your CT according to your need. I'll tell you how difficult it is to do for pediatric patients. Nursing staff, and also you would need post-processing workstation to get best out of whatever images you have been able to acquire. So we'll be talking about pre-procedure planning and patient preparation for these pediatric patients, performance of cardiac CT, how to do it, and then what are the techniques by which we can reduce the radiation, which is all the more an issue in these patients because these patients are going to undergo multiple studies in their lifetime. So if we talk about pre-procedure planning, there are multiple aspects to it, starting from the anesthesia situation, putting IV line, use of power injector, what are the contrast protocols, what should be the pre-procedure medication, how are you going to instruct or counsel the child, how you to position the child. So we'll discuss some of them one by one. So as far as anesthesia and sedation is concerned, see, doing a pediatric case anywhere, not even cardiac, is a nightmare. The patient usually will end up crying once you put in the IV line. So what we do is we usually at our institute, the patient comes 2 hours prior. So before he is posted, the IV line is put, the patient is soothed, and by the time he is in the console, he is already over the trauma of having undergone that IV line insertion. So as far as neonates and infants are there, they may require sedation. There is a lot of Western literature which talks about feed and wrap approach, wherein the child comes with some amount of fasting. And when the patient is, planned, so at that time, the mother feeds the child and the child is wrapped snugly and he goes off to sleep. But the problem is most of the anesthetists, they do not want the child to have had a feed when you are going to give a contrast or when they are going to give a sedative agent. So they want the child fasting. So that becomes an issue. But there is a lot of Western literature which has talked about feed and wrap approach. Then from 6 months to 5 years, usually again, they need sedation. You may need to immobilize the child also. Usually what we have seen is 6 years and older. Usually if we counsel them well, if they are soothed, they can be quite cooperative. And you can also have parent in the console to just soothe allay their fears. What we are using is a volumetric acquisition with ultra high pitch scanning. So that the table moves very fast and we are able to acquire the entire CT in one cardiac cycle. And this actually precludes the need for breath hold. And also it somehow negates the high cardiac motion. So anesthesia and sedation, we are using to a very less extent. And this is because we have a very high-end scanner. So scanner also matters a lot. So your anesthesia and sedation needs can go down if you have a very good scanner, which has got very short acquisition times. Talking about IV lines, obviously, if you have, we know the flow rates of all the, needles. So if you have peripheral, you have Venflon, which is 24, you are not going to put, so the rates are accordingly. So we put IV peripheral line, the Venflon according to what rate of flow we want. If there is already a PICC line, central line on indwelling venous catheters that can be used, provided they are not they have not been older than 48 hours. Umbilical catheters may also be used, but that usually give suboptimal contrast enhancement. As far as IV line, so where to put the Venflon, we prefer to use the upper extremity and on the right upper limb. On the left side, I hope my arrow is seen, yes. Is it? Okay. Yes. So the left, if you put it in the left upper lobe, there will be a lot of contrast in the brachiocephalic vein and you will not be able to see the arch vessels well. So it may lead to, so what we do is we put the contrast usually from the right side. So this is how the contrast will look like in the SVC. So it may produce streak artifacts. So if you have a patient with suspected PAVC, we do not use the upper extremity. We may take a lower extremity vein. If we have interrupted IVC, if the patient has gotten Glenn, bilateral Glenn, then also we may use lower limb extremities. In patients with Fontan, we use both upper and lower extremities, and we also take delayed scans to evaluate the circuit. As far as contrast volume is concerned, usually we give 1 to 2 ml per kilogram. So we do not exceed as far as possible to more than 2 ml per kilogram. What we use is a biphasic contrast injection, wherein we put a contrast which is followed by a 50% lesser volume of a saline flush. And in certain cases, we do also use triphasic injection. So this is a bit, so you can see the image on the left, there is contrast in the right side of the heart, but there is no contrast in the right side of the heart, but a lot of contrast on the left side. So this is something which we will do if we are interested in seeing the left side of the heart, or if we are wanting to see the aorta, we want the contrast in the aorta, or if we want to see the coronary arteries, we do not want any contrast in the right side to produce any artifacts precluding the visualization of the right coronary artery. So biphasic injections, this patient has been given contrast, which has been followed by saline chaser, and acquisition has been done after the ROI was put in the left side of the heart. So once the opacification of left side happened, the acquisition started. Similarly, if you have a patient with tetralogy, you're interested more in the right side. So we'll put our region of interest in the right side and acquire when the contrast is in the right side, so that the right-sided chambers and PA are the ones which are more well specified. Delayed phase will allow us to see both venous and arterial opacification without a repeat of the bolus. Triphasic injection may also be sometimes done. So when we want contrast on both right as well as left chambers, sometimes you want better contrast in the left chamber, sometimes you want similar contrast bilaterally on both ventricles. Sometimes you want better contrast on the right side. So accordingly, we can change and have our mix of contrast. So you may mix the contrast in the saline chaser to get these sort of appearances. The other issue is motion artifact. Like I said, these patients have got heart rates more than 100, and also they are not able to hold breath, especially the younger patients less than 7 years will not hold breath. So we need a scanner which will obliterate all these artifacts. So with the advent of CT scanners, you have seen the temporal resolution has become better and better. Earlier with 4-slice CT, we used to acquire the acquisition used to last for 20-25 seconds. Now with the dual source CT, we acquire it in just a half of a second. So in single cardiac cycle, we are able to acquire the entire acquisition, thus precluding the need for a breath hold. The other thing which we can do is for obliterating your cardiac motion is to have ECG gating. ECG gating will, the only problem is you are acquiring during certain phases of your cardiac cycle, and hence the heart rate control may be required. It is going to be a longer acquisition, whereas a non-ECG gated study is a shorter acquisition, is usually sufficient in older patients, on older children. However, in younger patients, whereas, for example, if you want to see coronary evaluation, it may be suboptimal. So what we have done is, because we have a good scanner and some very high-end scanners have this high-pitch non-gated CT study, which allows spiral acquisition, which, like I told you, is done in half of a second. So it does not have any motion artifacts, either because of cardiac or respiratory movement. So you can just see the difference between regular non-gated, a high-pitch non-gated, and an ECG gated study, which is done here. So you can, if you want a functional assessment.
I think we are running short of time. I would like you to conclude.
Yeah. So I just wanted to I'll just take 2 more minutes talking about assessment. So when we talk about assessing this CT, we would we would do a segmental approach, have a first look at the visceroatrial situs, look at the AV junctions and the arrangement of the AV valves, look at the ventricles, identify them, look at the atria and ventricle for any defects, the ventricular arterial connections, the great vessels, how are the positions, and any associated abnormalities. So this is situs solitus, liver on the right, and systemic venous atrium on the right side. And this is situs inversus. Atriositus, broad-based appendage on the right-sided, crista terminalis on the right-sided atrium, and you have the veins which are SVC and IVC draining into the right atrium, coronary sinus also. And if the IVC is interrupted, even hepatic veins will drain here. The left atrial appendage is a narrow structure, elongated appendage, and has got no crista terminalis. Regarding ventricles, the most important structure which can help you identify RV is the moderator band. Second is the presence of conal tissue between the tricuspid valve and the pulmonary valve, whereas on the left side, you'll have the atriomitral continuity. So you can identify the ventricles with this. And you look at the atrioventricular concordance, see whether it is concordance, discordance, double inlet RV or LV, or it is atresia. Then finally, we look at the ventricular looping, that is D loop or L loop, and then ventricular arterial connection, whether they are concordant, discordant, DORV, DOLV, or there is single outlet with either pulmonary atresia or aortic atresia, or it is truncus arteriosus, which is giving rise to both arteries, great arteries. Relationship of great arteries, again, L post aorta. Aorta is normally posterior and to the right of the MPA. So L post aorta is if it is to the left of the pulmonary artery, and in TGA it will be anterior to the pulmonary artery. Associated anomalies, we look at the great vessels. So look at the pulmonary artery, also at the aorta. Just I'm finishing off. Coronary arteries, any abnormalities in the skeleton or the airways. So I would like to conclude, tailor your study according to what is your indication. At the end, you want a diagnostically readable data set. Use as low as reasonably achievable radiation dose. And with the advent of dual source CT, it is now possible to do intra and extra cardiac anatomy with less than 1 millisievert radiation dosage. And for the analysis, use a segmental approach to get the best possible results. Thank you.
Thank you.